You might be surprised how little I talk about bariatric surgery, particularly given bariatric surgery makes up over half of all the operations that I do, and I've spent many years doing it. If you've watched pretty much any of my videos, you'll know already that I try to be very honest about both the power of these surgeries, but also about their shortcomings. You'll have heard me say that the surgery doesn't cure you because your disease is lifelong. However, the bariatric surgery is a very powerful tool in our toolkit to help manage long-term obesity and metabolic disease. So in this video, I would like to go through the rationale behind the procedures we tend to recommend for our patients, along with some of the evidence for this. There are many different bariatric operations, with new ones coming up all the time. I'm going to focus on the common, well-established procedures with good evidence base that make up most of the procedures done across New Zealand and Australia. When I first started doing surgery for obesity, the most common operation was the adjustable gastric band, or lap band. This was popular because it was generally very safe, but its results were variable, and as time went on, the bands started to cause more trouble than they were fixing. It's been many years since we used this procedure, and I've now removed over half the bands that I put in. There are three dominant procedures done across New Zealand and Australia currently, and this is largely the case for the rest of the world. On the one hand, we have the sleeve gastrectomy, and on the other, we have the two bypasses, the one anastomosis gastric bypass and the Roux-en-Y gastric bypass. I put these two into groups very deliberately because the two bypasses are actually very similar in many respects, while the sleeve gastrectomy is quite different to the bypasses. I'm going to discuss each briefly with their pros and cons and then explain the rationale behind what we generally recommend for our patients. Our recommendations have changed in the last 5 years quite significantly, and this change is based on both our own data and emerging large international published studies. The sleeve gastrectomy involves removing the outer part of the stomach, refashioning the stomach into a thin tube about the size of a small banana, but food still travels through the remaining gut quite normally. The sleeve mainly causes restriction in that you feel full with small amounts of food, and there is also a reduction of a hunger hormone normally produced in the part of the stomach removed. The main positives of the sleeve are that the risk of deficiencies in vitamins and minerals is generally lower, and endoscopy to treat bile duct problems is still possible. Its disadvantages are quite a high prevalence of new acid reflux problems after the short term and poorer long-term weight loss. It's often incorrectly described by surgeons as a less invasive procedure, which it isn't, because the stomach's largely removed, so it's not reversible. In our hands, its rare complication rate is the same as bypass, not less, and if a leak does occur, it's much harder to treat than a bypass leak. The Roux-en-Y gastric bypass has been around the longest and was initially adopted from its use in stomach cancer surgery. It causes restriction through its small pouch and also quite a powerful hormonal effect that reduces appetite. These are related to a number of hormones, including GLP-1, that are amplified after eating by gastric bypass. It is a powerful operation. It tends to reduce and not increase reflux, and it can be reversed in the rare case that that's required. But reversal is quite challenging. There are two joins rather than one, so the risk of a leak from one of these is slightly higher than with the mini bypass, and it does carry a higher risk of internal hernias and unexplained left-sided abdominal pain, although these are both quite uncommon. The one anastomosis bypass is also called the mini bypass, so we don't have to use the word anastomosis too much. This is essentially the same as a Roux-en-Y bypass, but with a single join. It has a longer gastric pouch than the Roux-en-Y, and the bile and pancreas juice flows past the joint rather than being diverted downstream. While it hasn't been around quite as long as the Roux-en-Y, it's still been in use for over 20 years. It's a very powerful operation. It tends to reduce rather than increase reflux, and it is reversible in the rare case that that's required. There is a small risk of bile getting into the esophagus, but in practice, bile reflux has turned out to be an infrequent complication. You can get internal hernias, but they're a little less common than with the Roux-en-Y. Both bypasses have a stronger hormonal effect than the sleeve, so are better at treating type 2 diabetes. So, what do we recommend? In the past, the sleeve was recommended quite commonly and is still recommended commonly by many surgeons as a first-line procedure. Large recent studies, however, have begun to show a picture of the sleeve as an operation with a significantly higher long-term failure rate compared to bypass procedures, and rates of conversion to bypass much higher than previously thought. Many patients seem to suffer troublesome reflux, and this mirrors what our data has shown us. I do want to briefly draw your attention to two significant randomised studies that look at this. The SM-BOSS trial was a Swiss randomised trial of 217 patients randomised to sleeve or Roux-en-Y bypass, and notably it followed them for 10 years, and you should know it's rare for follow-up to go this long with the randomised trials. At 10 years there was a 10% better weight loss with bypass, but perhaps shockingly 30% of sleeve patients had been converted to a bypass, mainly for reflux. A second trial also published this year is the 3-year outcomes of the bi-band bypass trial, notable for being one of the largest, if not the largest, prospective randomised trial of bypass versus sleeve with 1,300 patients. At 3 years, the difference in weight loss outcomes was surprisingly large, 19% versus 27%, and improvements in other problems such as diabetes and cholesterol also favoured bypass. Some surgeons may recommend the sleeve procedure, thinking it's the simplest and safest procedure. And in the past, this was a view that we held. Our view, however, has changed. We now see it as a more invasive because the stomach is removed and it's not reversible. Its complication rate in our hands is higher than the mini bypass, and the complications of gastric sleeve are harder to treat, particularly leaks. Some surgeons may say it must be the best because it's the most common operation done around the world. Now, to understand why this is said, you need to know that it is the easiest and quickest operation for a surgeon to do, and there are many bariatric surgeons who can only do a sleeve. Unfortunately, a surgeon motivated by financial factors may be inclined to offer the quickest and easiest solution rather than the procedure that's actually best for the patient long term. We believe that gastric bypass surgery is best for most patients, and we are so sure of this that we only offer gastric bypass in our public program, apart from some very specific circumstances when a gastric sleeve is the only option. For most patients, the mini gastric bypass is the preferred procedure. 90% of the patients in our public program have had mini gastric bypass in the last 3 years. Because of the slightly higher risk of bile reflux with mini bypass, if someone already suffers from severe reflux, then we would prefer a Roux-en-Y bypass for them. In addition, Roux-en-Y bypass is favoured for most patients having revisional surgery. Because of this approach, which is based on good data, you'll notice that your preoperative education will not greatly emphasise the sleeve gastrectomy unless there is a particular reason why it may be suited to you. We will of course be happy to discuss this further with you when we meet.